You're listening to Science and Saucery, a show dedicated to adding life to your years. And now your hosts, registered dietitian Juliana Hever and scientist Ray Cronice.
Welcome.
Hello, hello.
Hi, Juliana.
Hi, Raymond James.
We have a big show today.
Pun intended.
Yes.
We are so excited because we did our retreat in Thailand this year, and one of our students just happened to be this extraordinary woman filled with energy and wisdom and knowledge, and she is a urologist specializing in sexual health who happens to be a plant lover.
Right. So today is going to be our show on penis and plants.
Yeah, we're going to get a little sexy. And honestly, this is stuff people need to talk about.
It really is. And it's amazing that diet plays such a role. And it will be great to really talk about this to somebody who deals with it in the trenches. Yes, in the genes every single day. I mean, this
genes.
is
the genes with the J.
Yeah, the genes with the J. So
now this is so exciting, and let's talk sexy. It's okay. Yeah. It's good.
So, Cathy, welcome.
Yes, thank you.
Good to have you on today.
Oh, thank you so much for having me. This is an honor.
We've been really looking forward to this.
This is going to be fun. So, tell our audience a little bit about your background and how you sort of navigated yourself into this career, and we'll sort of go from there.
I'll go from the very beginning. I was born in Korea, South Korea, and I immigrated to this country when I was 4.5. So I kind of consider myself a banana, yellow on the outside, but white on the inside. But my parents, I mean, I've learned this as I gotten older, but they left everything, no money, no prospects, and just came to the United States with 2 children to live the American dream, to hopefully get the American dream. And when we first came, we went to New York because that's where my mother was kind of promised a job as a nurse. And when we got there was no job. So we had to kind of live with friends. And, I grew up in New York, Korean culture, very strong emphasis on education. And I've always, since I remember little, 6 years old, I said, I want to be a doctor. And part of that was because of my mom's influence being a nurse. And for me, I was, I don't want to be a nurse. I could be a doctor. And so all my life, that's all kind of what I was working towards, and I went to college in Boston, and then I applied to medical school. And
MIT.
I went to undergraduate at MIT. Mm-hmm. And the funny thing is,
she just didn't want to slip that detail in there. I wanted to make sure that we talk her up because she.
It's quite impressive.
The funny thing is, that was not my first choice. I said, this is not a pre-med school. I wanted to go to a pre-med school, and it had the best financial package. So I suffered and went to MIT. It was the most amazing experience of my life. One of those things, And when I always knew, did pre-med, did biology at MIT, and after I applied to school, New York, I applied to a school in New York City, in New York, for cost savings and things, being an in-state. But I deferred a year to travel around the world because I thought, I think I want to travel before I start my next chapter. So this love for travel has always been with me. And it'll kind of stem towards why I thought visiting Thailand and doing your course was just an amazing opportunity. But I actually spent a whole year by myself just going physically around the world. In those days, you could buy a ticket to just keep going west. And I think you can still do this now, where you could do a couple of carriers and keep going west. And, I had 2 places. This was in 1988 when Seoul had their...
in 1988, I was in Next House. So I was walking the MIT campus then that summer. Yeah, I went to a graduate program up there in 1988.
Oh, I know Next House very well.
Yes.
I mean, that's not where I lived. I lived in Baker House, but
Yep.
anyway, that's awesome.
But I know that whole time frame, and I was traveling with my friends from there to Europe, and that just it was a very different than it is today.
Oh my goodness, no cell phones.
Right.
You know, my mother kept some of the postcards I sent from Europe, from Asia, and these were, 2 weeks after I wrote them. God knows if I could have gotten abducted or who knows. I mean, just amazing how, it's so different now.
How brave and independent you were too, which says a lot about everything.
It's very, but it also taught me a lot about myself and sort of self-awareness and, how you can't control everything, and being a type A, quadruple A personality, you had to let some of that go. Because, I had no specific itinerary. I just kind of said, well, today I think I'll do this. I'll do that, made it happen, So it was pretty exciting, and I'd never give that up. And then I went to med school in Buffalo, New York. And I came to St. Louis. That's where I'm practicing now for my residency in urology in 1989. I did my residency there, 6-year residency in urology.
What made you choose urology?
Oh, I get that question all the time. So it's especially a woman, right? Because people think of urology as the male gynecology. And so when you go to med school, as you're going through the didactic classes and then the clerkships, you kind of first make the big choice of, well, should I do medicine or should I do surgery? It's kind of two big decisions you have to make. And for me, I love doing things with my hands. I loved operating. And so I said, I definitely want surgery. And then at the time, there were 4 subspecialties that you could do a direct program where you can do general surgery and then go right into the subspecialty. And urology was one of them. And the role models, the urologists that I met and worked with were happy. They seemed, just loved life. And I connected with them very well. So that's part of it. And then once I got into it, I realized urology, it offers so many things, not only the surgery, but also subspecialties. And a lot of the urologists keep their patients. It's a comprehensive, long-term for all your patients, because you can kind of treat them till, they get older into their ages, and then other problems that may arise, you can treat. So I finished my residency and then did a research fellowship, and then went to the Cleveland Clinic for a clinical fellowship in male infertility and microsurgery. So, my first love is trying to get the male partner pregnant, and also advocating that in infertility workups, you really have to pay attention to the forgotten partner, which is the male, because everybody focuses on the female.
Right.
And yeah. So I went back to WashU and was in their academic program for five years as faculty, and then I joined private practice in St. Louis, and I wanted to bring something to St. Louis that didn't really exist. And at the time, we were talking about sexual health. Viagra had come out for a while, and so people were more apt to talk about it because there was a treatment available. And because I did male infertility, it kind of partners very well with treating erectile problems and those kind of things. So I built this Center for Sexual Health as part of my private practice group, and I'm one of 9 urologists, and I focus really on sexual health, male and women, and then, of course, infertility. And because I'm a woman and there aren't that many female urologists, I see a lot of women, bladder problems, incontinence problems. So, but really the erections and sexual function has been sort of a special interest of mine.
So simultaneously during this time, I'm wondering at what point you realized that in terms of personally your diet, and then of course we had talked about the whole vegetables, not Viagra movement.
Right. In actually 8 years almost to this day, early in 2013, my husband brought home Forks Over Knives documentary with Esselstyn and Dr. Campbell. And we watched it, and it was like a light bulb went off. we both looked at each other and I said, wow, that's the answer. Of course. It's the diet.
So this is,
it's gotta be the diet.
And what's really great is, so many of the people we've talked to, like myself, came to these answers not from the traditional sort of vegetarian vegan perspective, but from sort of a health perspective. And,
Yes.
I don't want to skimp over the fact that initial drug, because this is, I think this is universal with most of the drugs that have a positive effect or treat a side effect, so to speak, of diet, of a poor diet.
Oh,
And the
yes.
fact that, Viagra wasn't an erection drug, Viagra was a blood pressure drug that happened to have these
Absolutely.
side effects. And so then, they go side effect hunting and say, oh, wow, marketing the side effect is more profitable than what we were looking for in the first part. And I want to say that now, because going back to what Juliana's saying about, when we realize that diet has some control, you see this directly every single day.
Every day. And so this was during the time in 2013, I was way into health for myself and my family. And to be honest, I did not really realize the impact of diet on my patients and their lack of health.
Because you're not taught that in medical school. At all.
No, absolutely. I always say now to my patients, doctors know nothing about medicine, nothing about diet, nothing about diet. We're not trained in nutrition. I just don't remember a course. You've had more courses, Juliana, absolutely, than I have had in nutrition. I was concerned for my own health, because this was a period of time when I was an avid, runner. I would run 2 to 3 marathons a year. I felt I was very healthy. I was even eating salmon 3 times a week because they told me it was good for omega-3s. And, I believed it was very difficult, because all around you, this is what you're hearing too. And even as a physician, you're a human being. So you have to have time to investigate and, figure things out. So the biggest thing was, I had my cholesterol checked, and I thought, wow, I should be off the charts great, because I exercise and do all this. I'm not overweight. But it wasn't all that spectacular. It was just okay. And I said, this is strange. What is going on? I don't think I can exercise anymore. And it's the food. As you guys always say, it's always the food.
So you saw this, so you saw the movie, and did that precede you getting your labs drawn and kind of analyzing it from a different perspective, or in what order, and how did that all come to light?
So I was getting, regular physicals, and, my doctor, like the doctors say to most patients, oh, your numbers look okay. Numbers look okay. And I said, okay. And, I would continue to exercise, because I thought that would be, a great, it helps with health. And, but again, I was not getting faster in my times, and not that I'm, any kind of, professional athlete or anything, but I just, for my personal, I want to go faster. I'm very competitive. And so I said, what am I doing or not doing? And initially I wasn't even thinking about the diet for my performance, but it has come kind of hand in hand, because I've learned that the diet, it aids so much in recovery, and just as you get older, it's the answer. So Tom and I, my husband, after that movie, it was like a light switch. We just immediately cleaned out our pantry, did everything, and we haven't turned back since. And we are both able to run marathons still. Everybody said, oh, again, the same question. Where are you getting your protein? Are you eating enough? You're exercising so much. I know.
Did you normalize your cholesterol to what we would consider a healthy cholesterol? Yeah.
Better. Yes.
Of course.
Below
Yay.
150. Of course. And then I started thinking, oh my goodness, this is what's missing in my patients. And since then I try to develop a program to teach, good eating. And every patient I see, I always talk about food, because no matter what, especially what I treat, I think of erections just like fertility as a marker of good health. Right? If you think about it, if you're sick as a dog, the last thing you're thinking about is, I think I want to have sex and make a baby.
Right.
It's the last thing you're thinking
I think some
about.
people have it on their minds all the time, sick or not.
But it is interesting because I have patients, COPD, breathing on oxygen, 100 pounds overweight, coming to me and saying, I'm having problems with erections, right? And of course you are. It's not what is causing my erection problems. It's what else is associated with erection problems.
Yeah, and I always like to say we have one cardiovascular system. There's one circuitry, and it's all connected. It's all one. We are one human body, and everything interacts in some way.
You're absolutely right. And I tell the patients, if you take the time to talk to them about it, if finally it gets to them, I said, look at you. Your body is so busy trying to keep you alive. This is the last thing it's thinking about. We need to get you, I can offer you medical treatments, and there's only 5 medical treatments I can offer you. But in the end, it's going to be better for you, overall health, everything, and not just the erections, but, you have to change your lifestyle. And of course, I get a lot of nods. Everybody knows you should eat more fruits and vegetables and you should eat to the right. But it's one thing to acknowledge it and another thing to, execute it. I mean,
do you think that, people may have these fears of, when they get a diagnosis, especially something like cardiovascular disease or something like that. But do you think that, and a lot of them, of course, there's that huge gap from the patient perspective and from the most healthcare professional perspective that diet isn't even connected, that has nothing to do with it. But do you think from a patient perspective, if they're getting this diagnosis of specific or a symptom, I guess you would call ED, right? Would you consider that a symptom? Do you think that would be because many men, it's important for most men? I don't know. I can't say, but do you think that would be more of a good incentivization for them?
Yes.
Okay.
So that is a very good point, because my illustration of the 100-pound obese male on oxygen, the thing that brought him to the office was the erection problem.
Right.
So no matter how sick they are, no matter if they can't look down and see their penis, they want to have erections. It makes them part of who they are.
Right.
It makes them part of being a man. It makes them, it makes them whole. So that piece is missing if they're not able to perform or satisfy their partner.
And I was just going to say, the other side of this is, when we're looking at this, even when we look at the health span and longevity research, fecundity and longevity are inversely related in many, many organisms. So this idea, and using sort of the opposite side of this, which is there are many things that might make someone short-term more fecund, but long-term have a detrimental consequence, meaning, you live fast and fizzle out,
Right.
So in other words, there are things that can be a positive evolutionary adaptation, which makes you feel great in the mid part of your life, but then also bring on age-related disease. And of course, really erectile dysfunction is really the canary in the coal mine for cardiovascular disease. It's sort of the first sort of symptoms of that going awry. So it is related to fecundity. Erections clearly are. However, the other side of that is that it's sort of a side effect of this other issue, which could, you could be perfectly within sync with an evolution. It could be an evolutionary advantage to reproduce and pass your genes on young and then not live long. We don't have a feedback loop for genes after reproductive prime is over. And so this becomes one of those issues specifically. And so what you're talking about is an intersection of social self-worth, now that we can live a longer life, and this sexual function, which is then related indirectly or directly to this cardiovascular disease issue.
And back to identity too, Cathy, it's so ironic that if you think about, there was a backlash from Game Changers about this whole stereotypical thing with males and fertility and fecundity and all of that. And there's this whole backlash because people really believe that eating meat is so masculine, and you look at the advertisements. So there's this kind of weird identity crisis, if you will, when it comes to eating animals and having a good sex life, I guess.
At misinformation, misdirection. But I think a lot of people just like I find it amazing that some people can stick to a specific diet and have the discipline to do that. But if you look around, they'll choose diets that they can sustain and tolerate. So if they can do the Mediterranean, and they're okay with oils and things, they're a big fan of that. But I always try to explain to them the reason why you're doing well on that is because it is adopting a lot of the plant-based things that compare, like you said, Juliana, compared to what? Compared to, a standard American diet.
Bottom feeding.
More fruits and vegetables. But I think, your point about what drives people for health, I think we have something here if we can advertise to people that, this might actually cause erection problems. People might look at it a different way. And I think I'm so glad that was included in the Game Changers because it is an important aspect of quality of life. As you said, we're living longer. People want to not just live longer, they want to live well longer. And part of, it's interesting when sexual activity is not part of a couple's relationship, it's like 90% of the problem. If it is part of the relationship, you still have 10% of couple issues, but it becomes a big elephant in the room. Literally, if a very
see all the jokes are starting to happen right now. I hear you out there thinking. We're recording this before you heard it, but I know exactly what you're thinking out there, guys.
Wait, so Cathy, so with that in mind, I'm really curious. I have so many questions for you. I'm really curious about how your patients then respond, specifically when you're coming at from this angle. I'm also curious about how everyone around you, physician-wise, responds. But start with the patients, because what do they think?
So when I have a new patient come in for erection problems, they don't leave my office without getting the spiel. The most important thing is going to be the 4 things. I always say erections are a marker of good health. Your erections are going to be happiest and healthiest when you are happiest and healthiest.
Aww.
And it's true, right? Because in my mind, there's 4 things that make you happy and healthy. It's the diet, your exercise, your sleep, and your stress reduction. And if you think about it, if all those things are optimized, your erections are going to be optimized. There is a psychological component to sexual health, right? So if you're stressed, if you're thinking about finances, if you're thinking about, your partner, baseball, it's going to go down.
Baseball.
It's going to go down. So that is a reality because stress releases chemicals that, bring erections down. It's almost like a protective mechanism. If you're under stress, flight or flight, the last thing you're thinking about is, I think I should have an erection. No. That's the last
I think some people would argue again.
Depends who you talk to.
This is why they come into the office, because they're thinking about this so often that it at least gets their attention. They
matter that they can't breathe.
Yeah, they don't mind they're short of breath.
Right.
Yeah.
I said that could be limiting your sexual activity because it's physical activity. And I always stress the sleep. We used to think sleep wasn't really necessary, but it really does help in repair. Just like, Ray, you're talking about periods of fasting that lets your gut rest and repair. Sleep is so critical. And then, exercise. If you ask me what's more important, exercise or food, it's always the food.
Yeah.
But I do promote, being active. Sitting is the new smoking. But when I say, the most impactful thing immediately that you can do to help yourself is to change your diet, they all nod their head, yes, but they realize they're not wanting to hear what I'm saying because that means they have to change. It's very difficult.
Right.
Major.
So very difficult. But I always, and there are a few that say, you're right, Dr. Naughton, I don't want to be sentenced to a medication all my life. I'm going to try this, But the problem with diet changes and lifestyle changes, it's not immediate.
Right. And by the way, that's on the other side of the issue. That's also the problem because, you have, the new carnivore diet or the new paleo diet, or, something come along, and these issues aren't going to happen until after reproductive prime, most of the time. And so there's the delay. And during that interim time, you actually feel really great.
Right.
I mean,
Right.
again, this could be completely consistent with evolutionary success. And then at the same time, it could also be negative in terms of long-term mitigation of age-related chronic disease.
Right. And that's part of the reason, like you said, the motivator of doing something. If if you don't have any side effects or symptoms of having high blood pressure, you're less likely to take your blood pressure medication because it's a silent kind of disease that you don't really go around checking your blood pressure nonstop. But erections, it's in your face. This is not working.
That's another one right there.
Yeah,
pun intended.
It's not working. And then it sets up this vicious cycle of psychological self-esteem, self-worth. I mean, it drives people. It drives people to me. And so it's interesting that even as important as it is, if I told them all you had to do is change the way you eat, you would think, of course, this is I always think of Esselstyn. What is more dramatic or drastic, having someone cut your chest open to do a bypass or changing your diet?
And many people will err on the side of changing your diet because they want the quick fix. They want the pill. They want the procedure because it is. I mean, I always say that food is so deeply embedded in all of our lives. It is like defines who we are and our history and our relationships and everything we've experienced, our culture, everything. And so having to make decisions that are so intense, especially coming from what most people are coming from, it is a huge step. But you would think that this motivation would give it even more of an edge than other things, which is what's so kind of exciting about what you're doing.
But I would say 90% of my patients, even after I'm spieling on my soapbox, I mean, literally, they're like, Dr. Naughton, can I leave? Can I just have the medication?
Wow.
I'm so passionate about this that I make it a point because I feel like at the end of the day, that is my job and I push it every time. And, but I would say 80, 90%. Now, that's in the age group that's older. So men that are, between 50 and 80, right, that come to see me, they're more likely to nod their head because they're more set in their ways, right? They're more set in their diet. Now, that's why I think that game changer scene with the young kids, I think that's where you're going to make the most impact because I find in the younger patients that come in with some problems, even 30s or 40s, that's because a lot more 30s and 40s are obese and have other problems, right? It all goes together. They're more apt to change or try to change their lifestyle. And so I think we should hit them early. That's the message should be, hopefully people younger are listening to this too, that, it happens just like cardiac disease happens when you're a baby. The vessels that feed the penis are the same that feed the heart. The endothelial cell dysfunction is the same. It's identical. So, I mean, there's going to be some effect.
Fatty streaks start at around 15,
the Bogalusa, I think, went to 12.
Yeah.
I mean, no, it's
so,
yeah,
but,
and
what's so important about this is that one place where I think medicine and sort of medical communication at large in terms of health communication is, I actually see obesity as a side effect of the same problem, not causal. And there's so many things that obesity is associated with and, like diabetes, but the truth of the matter is if someone is type 2 diabetic and they're overweight and they change their diet way before they lose their weight, their blood sugar and blood glucose control will normalize. So it's not causal in that way. However, when you see obesity as a symptom of the same problems, when you put it on that side and not on the causal side, I think people can think about it. For example, with erection, when you say, look, not only are you obese and you can't see your penis or the joke, things don't grow in the shade, right? But also that this erectile dysfunction is a symptom of the same problem that obesity is a symptom of. And,
Right.
Whereas I think in the past we would say, you just need to lose some weight and things will start working again. And the truth of the matter is they'll probably start working with the obesity if they just change their diet.
Right, exactly. That's what I, try to convey. And but it is amazing how difficult it is to get someone to change their diet or change their lifestyle, even for that, because they will ask, well, what are the other options, right? What can I take? What other medical therapies can you offer me? And it's, to me, I feel if I get one person to change, and I have, and it's the best day of my life, because
Yes.
they'll come back and they say, yeah, it works great now.
Tell us one of those stories. Tell us one of those success
I
stories.
love that.
So, classic, most of my patients that come in are in their 60s to 70s with erection problems. They've already tried medications, and of course, if it doesn't work from their primary, that's where they're coming to a specialist.
And you might also add right in there that that the medication actually works for a while and then it stops. Because
Right.
Can you explain
That's
a little
right.
bit of that before we get into this? Because
Right.
you talked about this in our class.
Yeah, so everybody thinks it's a panacea, and they think that is going to help them. And to be honest, most patients do get some effect or efficacy from Viagra, Levitra, Cialis. Why are there so many out there? Because not all of them work for all people, and eventually they start needing a higher dosage, or it stops working altogether. And part of that is disease progression.
Right.
Their underlying problems. They're not changing the way they eat. They're just using the medication.
Symptom management. That's Western
Yes.
medicine.
That's exactly right. And so then, there's only 4 other options. There's a vacuum pump. There's medicines that you can put into the penis opening. There's injections that you can self-inject the side of your penis with a needle.
Oh, that sounds cringy even to me.
Right.
Oh.
Or surgery. I mean, I could put in a prosthetic.
Or you could eat soup, salad, sides, and sweets.
Right. I mean,
Don't be crazy.
I mean, these surgeries are online, and if you look at them, I mean, even I cross my legs, and I do the surgery. So it's interesting that, and not all of them work either. I mean, actually, after the medication, if you're really serious about having an erection, then I would suggest doing the injections. And, of course, putting a needle into the side of the penis. I mean, some people just don't even like a flu shot. So the thought of putting a needle in the side of the penis,
This is a whole new definition of crazy pants.
Exactly. But, again, that drive to perform is so high. Men are willing to come, and I show them how to do it. And, it works. That's the problem. But it also has side effects. If it works too well, you can have priapism, which is a rock hard erection for 3 to 4 hours. I mean, it sounds good, but it's really not. And it's painful. And we have to do surgical procedures to get the erection down. So, there are side effects to these medications.
This is crazy.
Therapies, obviously. Right. And if you think about how...
The things we do for love.
Right. Exactly.
Walking in the rain and the snow is nothing compared to injecting your penis.
But a lot of my patients, they do that. So I think that we definitely have something here that we should try to utilize, the drive of human beings on what brings them to the table and what can have them change behavior. But as I said, it's more likely if you're a little bit younger and not already on medications or relatively healthy, and you're showing signs of erection problems, they're more apt to, well, maybe, okay, should I change my diet? What can I do? They ask me, what can I do? And I say, be careful what you ask me, because I will tell you what you can do.
If you ask me, beware the answer.
So do you have any example? We were going to go back to the success story. Before the success story, do you have any examples of people who come in presenting with problems younger that you feel may have that problem may be identified with some of the more extreme diets that could exacerbate it even earlier?
Yes, I think, well, even my younger patients, they're morbidly obese now. You have childhood obesity it just extends on. I have, 20, 30, 40-year-olds that most of my patients are obese.
Right.
And I'm in the Midwest. And again, they feel like I'm only 30. What's going on, And you're right. I say you're only 30, but you have been abusing your body with the diet for, many years. And it's, as I said, the genetics, everybody likes to blame genetics for hypertension, diabetes, all those things. Genetics, there is no gene for hypertension. I think your genes can have an impact on how it responds to toxins that you introduce into your body. But, to say that I have hypertension because it's in my family,
so is food.
Right. It's because your family probably eats the same food.
Well,
that's probably why it's in the family.
The genes, not the gene. It's like you're following your family. Right. But yeah. But what's so interesting is that people say, it's their genes because we have all sorts of genes. Like we have all sorts of things that can be there. But the more important thing, and what's so interesting about the newer evidence, I mean, it's actually not that new anymore, but all of the power of epigenetics and our ability from diet and lifestyle to turn on those genes and suppress those genes, because we're going to have something is going to get us. And lifestyle is everything that controls what actually becomes expressed.
Absolutely. But everybody loves that line because it's such a great excuse, because it basically releases you from any responsibility.
That's right.
And, it releases you from having to change anything. You can say, well, it's in my family, but I usually tell them what they don't want to hear. But, some of them I get through and
So tell us that success story, because I interrupted us earlier and got us off on the
Again, 50 to 70 pounds overweight, wanted to have erections. He, didn't really have, because everybody says, I say, you're overweight and, you're morbidly obese. And he goes, well, I just checked. This is a classic line. I just came from my primary doctor and he says, all my numbers are fine.
Face smash.
Yes. And the thing is, I find it amazing that, the labs, it can't reflect reality, because it's true. I look at labs and they are within reference range, or that reference range is really wrong. But you look at them and I say, no way that you have a normal glucose. There is no way you're not pre-diabetic. There is no way that you have, no hypertension. So it's a kind of a false sense of security.
This is what I love about you, because so many doctors are so scared, this whole fat shaming movement and everything. I know so many physicians that will not say it to their patients.
Oh no, and I said, I wouldn't say this if I didn't care, because it would take less time for me to just write you the prescription and let you leave. It takes time to talk to patients and explain to them. And that's part of the reason why there's also a difficulty, even in the physicians that want to do the right thing or know the right thing to do. There's a time pressure when you're seeing patients, and that's the reality of medicine, unfortunately. We're bound to documenting everything. How quickly can we get the patients in and out? It's difficult when you've got to talk about hypertension, diabetes, obesity, and all these things at one. I have a little bit of a luxury because I'm a specialist, and so people come to me with one specific thing, but interestingly, no matter what they come for, it's always the food, whether it's kidney stones, whether it's erection problems, whether it's infection, because they've suppressed their immunity by eating terribly, that their body can't fight off bugs that live with us all the time. Mm-hmm. It's always the food. There's some element to the food. So I think every patient I see, if nothing else, you should eat more fruits and vegetables. And, they give me the nod. But no, then I say, no, you really should eat more fruits and vegetables. And I think part of the passion is because I'm all in and I am so committed to this and I'm living it.
I'm
living it.
I should say easier for everyone that's listening that hasn't met you, like you are the walking epitome of what you say. Like, you are what you say you recommend. Do as I say and as I do, because that's what we're so impressed. You're very, very, very fit and very energetic, as everyone could probably hear. But you live this life. Like, you are 100% behind this. There's no.
I'm 100% behind, and I think it's easier to advocate something that you truly live, right?
Yeah, my internists. I've had 2 internists that are morbidly obese, and they don't want to talk about it.
Yes.
Yeah.
Well, why don't they want to talk about it? Because they can't tell patients to lose weight if they look in the mirror and say, I should lose weight. It's just there's too much inner conflict to start that conversation with someone, a patient, if you know yourself to be overweight. And I think that's a problem. The problem is doctors are human beings,
right,
just like everyone else, subject to the same addiction to salt, sugar, and fat, just like everyone else. And I was thinking about your other podcast, Ray, with Penn about data and how it's predictable, right? I mean, when you
can predict the
fast,
future.
Yes, when you can see these patients, you can see what's going to happen. And I said, you're a walking time bomb. I said, okay, this is for your general health. We need to change. This is going to kill you. This is going to kill you. The obesity, the poor eating, your lifestyle, so I spend a lot of time, but I enjoy doing it. This is what I believe in. And I'm just hopeful that some of it goes through. And it's sort of like the squeaky wheel, hopefully will get fixed. And if I continue it, and I have patients that I say it so many times, they're like, oh yeah, I know, you told me about this last time. But again, the funny thing is I see them 3 months, 6 months, a year later, and nothing's changed.
Yeah. And this is, this goes back to a paper that we quote in most of our papers that we've written. But this is Sick Individuals and Sick Populations, written by Jeffrey Rose. It's 2001. I don't know if you've read this article, but one of the things he opens up is that physicians have stopped doing is asking a simple question: why did this patient get this disease at this time? And they don't. What they're immediately looking at most of the time is, at the highest level of existence, it's, I don't want to be sued. So it's a litigious sort of framework. Right. So that then invokes generally accepted practices. So that means let's not deviate much from what we're generally doing, what everyone's doing, which creates herd mentality, right? And then it's the business propositions, which you can't blame a physician if this is, and again, if we don't call them patients, if we call them clients, because I think it puts a better framework on it. If you go to your client and your client wants this solution, and it's a profitable, and it's also a great solution for you, meaning, you don't have to talk as much. You can write the prescription. In other words, it's great for the business. It's great for the client. Then if you look at this series of things, there's no place to say, why did this patient get this disease at this time? And then to go back, 2,400 years earlier than that, and think about what Hippocrates says. He talks about making the patient doing it, and I don't have the quote right in front of me, but how do we make the patient comply? How do we comply ourselves, and how do we make the patient comply? And so going back to those internists that Juliana was talking about, or in the situation with you where you are the living example of what you're talking about, when in the 50s, when smoking and telling your patients that you need to start moving away from cigarettes and move away from smoking, when that was the thing, physicians were one of the largest populations that were smokers. So they are all coming in after their cigarette break telling this guy that he needs to, or woman, that they need to stop smoking. And so, this is where this food thing becomes such a problem, because they don't want to believe, first of all, that there's a causality there. Secondly, most of their patients don't get better. Right? I asked one of my collaborators, how many of your diabetic patients get better? And the answer is very few. They just start on a whole series of medications, and they just go down that, whole, pathway. Nathan, 2002, wrote in New England Journal of Medicine, where he sort of lays out the when you're diagnosed with pre-diabetic and on to, down to here's medications, early intervention, and then eventually it goes into the microvascularization issues and all the things that go into cardiovascular disease at the end. And that pathway of 20 years is pretty much what you're going to do unless you make a change. And so, getting back to this is this idea of being able to go in and say to someone, listen, if you change your diet in this way, we expect to see these results. And, Juliana will always add, results are typical, because we don't have to exclude them. We see all of our clients lose weight the same amount. And so my question to you is, what is if a person is sitting here today and is beginning to have erectile dysfunctions, how fast or how quickly would you expect to see if they went 100% as eat the way the three of us would recommend they ate? What would you think how would that play out over the next, weeks, months, or however? How long do you think it takes for them to actually start seeing a difference?
Of course, it depends on the person, and it also depends on how cold turkey you're going to go. Honestly, I mean, I flipped a switch, and a lot of people can do that. A lot of people need a progressive way to transition into this plant-based food. Of course, the results are going to be faster if you can do it cold turkey.
So let's say they go all in. Let's just go all in, because we're all about extreme and let's make it happen.
Right.
And I'm not going to
Yeah.
exactly. We're going to say, let's just do it. If you don't want to do it, then go do something else. We're about, let's get it done. So the question is, how quickly might someone, we saw that there was, in terms of erection frequency and erection, I don't know what the other metric is.
It was like how big it was.
Yeah. So in those two things, when they measured that in Game Changers, in both of those cases, they saw an immediate that night.
Response.
So the question, what would you expect as a urologist? What would you expect if someone comes in and says, okay, I'm going to go home with the health span solution and I'm just going to start eating vegetables, fruits, whole grains, legumes, mushrooms, nuts, seeds, herbs, and spices.
Right.
How quickly do you think they could see a change?
I think it kind of depends where you start. If you're morbidly obese, you might need more time to make those changes. But I see patients within 3 months after starting. I say, I want you to stick with this for at least 6 weeks, and let's see how you do in 2 to 3 months. By 2 to 3 months, they already show improvement and or no more problems with erections. So it can be pretty quick in terms of consistently having erections that are reliable. But again, as you know, not every erection is perfect every time, even in the best of circumstances.
Wait. You're assuming that we know that, but pray tell, I don't know about that.
So there's a lot of things that go into erections, right? And part of it, it depends on how tired you are, how psychologically into you are, how much your partner is participating. I think not every encounter is exactly the same. And a lot of, especially my young patients, come in thinking that it's going to be exactly the same. And they get all concerned, panicked when it doesn't work perfectly the first time. And then it sets up this vicious cycle. And so I treat a lot of, the psychological component of it as well. But if you ask me about how food can actually change someone who already has erection problems, I would say, in a biologic level, I'm sure it's very quick. But in terms of sustained ability and having them report that it's fine, I think it's going to take, 2 to 3 months depending on where you start.
We've heard from more than one client about at day 60. That's why I wanted to hear what you said first before I polluted this. But around day 60, because a lot of our clients are 12 weeks, and so that's around 50 to 70 pounds. And we've heard more than one person say, "Oh my gosh, I don't know what happened, but suddenly I'm a teenager again." And we usually joke and send them the PETA commercial.
Oh gosh,
BWVK boom. Right. If you haven't seen that, Google that commercial. It's kind of really funny. But anyway, the idea that, people really do see a major difference.
Right. And this is something that we should be advocating, advertising,
Yes.
educating, instructing. These are, the benefits, the amazing benefits that you can gain. Not just, a lot of people will come because they want to lose weight, right? That's the number one reason. But there's so many different things that you can benefit from that you don't realize. But in the erection problem patient population, I mean, they have already come and presented themselves and said, I have a problem, help me, and this is such a unique opportunity for all physicians, because I'm not the first person that patients come to. They don't come to urologists necessarily. It's the primary care physicians, right? That they're regular doctors that they'll come and complain about erection issues. And because we have medications now that we can write, a lot more patients are willing to present themselves and share this complaint. But the problem is we have to educate the doctors, and we have to educate them to teach them how to, I think first to teach themselves, right? Because again, the rate limiting step is going to be, if the physician is obese, if the physician smokes, he's going to have a hard time, she's going to have a hard time convincing the patient. The patient will look at the physician and say, you're telling me to lose weight? Look in the mirror.
Yeah,
exactly.
Right.
It just doesn't fly.
Does this also, let's talk about translating to women's sexual health. How does diet translate over there, and what are some of the symptoms, and what are some of the things that you may have seen on that side? The penis is one of these things where it either works or it doesn't,
Right.
So unfortunately, you guys are a lot more complicated.
And I alluded to this in Thailand, that the men it's like a little light switch. It's up or down, right?
Right.
Women, there's all these dials and maneuvers and gauges and toning. Women are much more complicated. It's a lot harder, therefore, to measure what's successful or not, because in terms of, you talk about female sexual dysfunction, number one, it hasn't been studied quite as extensively, because part of what drives research, and this, right, is funding.
Right.
And if you don't have a company or a drug rep or something to fund research, it's going to be very difficult.
Well, and there's also always more research done it's male dominated in terms of studies, like just in terms of looking at results. There's not as much, not even close to as much as we need on women.
Female, especially for sexual function, because
right.
It's women never complained about it, or never, so the number one, there's lots of domains of sexual dysfunction in women, and one of the most common is lack of desire. So it's not stimulation problems, but loss of libido is the number one subdomain of female sexual dysfunction that is most complained about. And so loss of libido, there's so much that goes into it. The psychological component and social, history of abuse, all these things. So I see the female side. That's one of the other unique things about, my practice, is I actually treat the couple, just like infertility. It takes two to tango, I say, at least. And the women, the biggest complaint is going to be loss of interest because of pain, right? Pain is a reinforcement for is a negative reinforcement for any activity. And so if you're not getting anything out of intercourse, but you're getting pain, of course you're going to avoid it.
Right.
So with women, there's a lot of medical and, psychological things that I have to rule out and things like that. But there is, again, no Viagra for women. Now, some physicians use Viagra or the PD-5 inhibitors like Cialis and other drugs off-label to try to treat libido, but really
what's the rationale there?
Yeah, no, there is no rationale for libido. It's increasing blood flow. So
right.
The thinking is, if you increase clitoral blood flow, just like you increase penile blood flow, then if someone feels different sensation down there, they're going to want to have sex more.
Is that not true? Is that not true that it increases the blood flow and improves the...
It does improve the blood flow, but again, they've done studies where, does it help your libido? No. There's a lot of disconnect with women, and like in men, if they see an erection go up, they want it, the libido goes up because for some reason
it's a feedback loop.
Yeah, it's a feedback where you see some positive results, and then but in women, that's not necessarily the case, because there's so many other things that, can go into libido. So right. For women, it's a much much more time and energy and comprehensive, treatment plans, like with psychologists, gynecologists, urologists. But we can't ignore this forgotten partner. Like in infertility, the male is forgotten, but in sexual function, in my mind, it's the women
Right.
that have been forgotten. Yeah.
And one of the things to think about, and this is an oversimplistic way, but, we often talk even with our clients, about the metabolic winter hypothesis, for example. It's a framework to sort of look at how we biologically respond to the season. So, it makes sense. Every other organism in your backyard responds to the seasons. And yet, what are the seasons? Temperature, food availability, light, and in some places, water. If you're in a arid or desert area, it would be water. But the fact of the matter is there's this finite amount of inputs because they don't have iCal, they don't have Outlook, and so that's
Right.
kind of the thesis of that. But we also talk about with our clients bird brain, which is somehow birds know how to make their bird nests. And, a robin doesn't accidentally make a swallow nest or an eagle's nest. It doesn't just accidentally happen. And yet they don't go to bird nest school. They weren't there when their parents made the nest, and they just lived in the nest. And so the point is they learn how to do it. So these are biological. These are part of the real genetics when we talk about genetic traits. And when you think about the responsibility of bearing the child and all the things that go along with that, and know that we have these genetic survival traits built in, like appetite is one of them. We tell people they're not broken. Why are you not broken? Because having an appetite in a calorie-scarce world is not a trait of negative selection. It's actually a really good thing to do. Those people that didn't eat when food was rarely around probably don't jump into the gene pool with the same gusto of our real ancestors that ate everything they possibly could. So
Right.
once you take away you're not broken, you don't have a broken metabolism, you're not that. And this, I'm going to do the same thing here on the sexual dysfunction side. Once you take away that you're not broken, then these other things present. And, an oversimplistic way to look at men and women is women need a reason, men need a place. When
Right.
you just said, when that guy gets that erection, he wants to place it somewhere. And
Right.
women on the other, and what's the response? What is the evolutionary responsibility of that? Well, for men, the best evolutionary response is to basically impregnate as many
Mate.
women as you possibly can.
Absolutely.
Whereas women
Yeah.
have this idea that you want to have more to this foundation. I have this child, and humans are helpless for years. Maybe sometimes
Right.
15 or 20 years. I mean, there's
Right.
probably some children out there that are helpless at 29. But my point I'm making is that in a real sense, human development is so slow that there is a huge biological component to this, and this has to play in, this bird brain has to play into what you're talking about when you're talking about
Yeah.
complexity for women versus men.
Yes, right.
You
You
know?
are you nailed it. I mean, why are women, again, sexual activity, it's a physical activity. If she's been working now, expected to work and coming home and taking care of the kids, making dinner, putting them to bed, it's the last thing on the list. Sex is the last thing on the list. It becomes, when you're so exhausted, you're not going to die without having sex, but the kids have to be fed. They have to be put to bed. They have to be bathed. So a lot of the sexual dysfunction in women, you have to kind of analyze and talk to them about what's going on in their lives. What else is going on?
And to bring back the plant-based diet, or the eating to the right of the triangle part of this, and what we've dealt with our clients a lot, is that women who are unhealthy, or they're not at their healthy weight, they're not feeling good about their bodies, that has a huge impact. And we see a lot of our clients, so they bring in this healthy diet, and they are feeling more confident, and then stuff improves on their end because of that.
I think, Ray, you're absolutely right in terms of this evolutionary kind of how different men and women are in general. Women are so affected by body image, self-image. Part of that is culture. Part of it is our cosmopolitan magazines.
Yes.
Can't be thinner, can't be, thin enough. But men, I talked to you about the 100-pound obese male on oxygen. He thinks people should have sex with him.
Right.
Do you know what I mean? I mean,
Well, no,
there's no.
And look, we see this with our client. If you take generally speaking, obviously, I know there'll be people out there that get upset because, we're now talking about genders, but I'm going to go with what we see and what the data is. And because I see the world as I see it, not as I want it to be. So generally speaking, when our male clients come in, typically their partners, their spouses tend to be very supportive of their change. Okay, what can we do? I'm going to cook for you. I'm going to do, I'm going to be supportive. Right. And then their friends tend to be really antagonistic. Hey, Joe, we're going to go get burgers. Oh, I forgot you're eating broccoli. Right. I'm sorry, and they give him hell. And then as the guy loses weight, what ends up happening inevitably is that they get down to a certain weight, and all of a sudden their spouse, who's quote unquote eating exactly as they're eating, but they're just not losing. Of course, they're not. They're eating differently because our women clients lose weight just as rapidly. So what happens is that they then get to this point where now he's feeling good about himself, and she's like, oh, I don't feel good anymore, right? So now she's becoming a little antagonistic about the situation, and he's now feeling good. And what's really funny is now his friends, if you look at a lot of these guys, they'll say, hey, Joe, get out that picture. You will not believe how fat this guy was. Now, this guy could have 3 chins and his belly rolling over his belt, right? And he will brag about his friend losing this weight. Now, on the female side of things, what tends to happen is that in the beginning, their husband, and it even actually goes in our lesbian and gay partners too. It happens actually. It's just a male woman thing. It seems to be that their partner tends to be not as supportive. The women partners are more supportive in the beginning. The male partners are less supportive in the beginning. Like, why do you got to change? And then what happens is now she starts losing her weight. And she gets down, and suddenly her husband comes in. Now, he doesn't care what he looks like you were saying. He could be on oxygen. He's got an erection. He sees his wife come in, and, oh my gosh, where did you get those jeans? Like, when did you? Suddenly he realizes she's lost the weight, and he can't get her clothes off fast enough. And yet, her friends are now saying, we've really been watching what you're doing, Cathy, and, we think you have an eating disorder, and, you're losing weight way too fast, and how much farther are you going to go, and we see this over and over again.
Right.
And it's really interesting how this plays out, and I feel like this overlaps what we would expect if you put this generic idea of this women need a reason, men need a place as an evolutionary explanation. And again, there's so many social functions here. We're not getting into the detail. I'm really talking at 30,000 feet here because this is not explaining that. Right. Or dysfunction. Right.
Yeah.
So the point is that social constructs do make a difference. But my point here is that it really seems like when we're talking about women, that there are a lot of more complications about what they have to do, but that kind of seems to make sense in terms of having this responsibility of carrying the child for 9 months and maybe caring for that child because, the father wasn't there, or decided, to go somewhere else, So, you see this and it just to me seems like something that at least relates to this libido side of it.
No, I think you're absolutely right. And I think part of it is the evolutionary. We're just different. We're just different. I mean, we have to embrace it and try to work with that because it's hard to change, the evolution part. But it's also how men and women are kind of brought up, whether it's our culture, how, men understand there's a leader and you follow the leader and everyone. And women have a more sort of, we're all in this together. We should all be the same. As a physician, I had a lot more backlash from female nurses because I was a female doctor. And that's because the nurses didn't see me as someone above them. They couldn't. And so, I got treated a lot differently than my male counterparts. And it is what I've gotten this far because I understand that there's differences. And if you can go on and be angry and fight it all the time, or you can accept it and kind of, work around it because that's just the way life is.
Right. Because we're not talking about better or worse. We're just talking about things that need to be managed. And what we see is there is absolutely a difference in how we approach libido, how we approach sexual dysfunction. As you say, men, it's going to bring them in to getting seen, and women, it's just, a lot of them are just going to suppress it and say, well, that's just what it is.
It's very interesting because a lot, I do the infertility as well.
Right.
And I have women who will withstand painful intercourse if it's in the name of getting pregnant. They will withstand, dyspareunia, painful intercourse if it's necessary to establish, because that reproductive drive that's in us is so great that whatever it takes, as soon as the baby's born, no interest, because it hurt. And then I find out, well, it's always hurt. But when she wanted to get pregnant, it was tolerable.
It was
she
worth
made
it.
it tolerable. It was worth it. It was worth it. And so, it could all stem from, it's a ROI, right? Risk benefit ratio, return on investment. If she gets nothing out of sex as an act, whether it's a great orgasm or a feeling of intimacy, if there isn't anything of value to her, it's going to be less desirable. Because for women, there's going to be other things that make up that ROI. Does that make sense?
Yeah.
100%.
And so what other kinds of diet related things do you believe, if you were just going to hypothesize or a blue sky a little bit, what kind of things besides just the self-worth or the body image or those things that, that get talked about more frequently, what kind of other physiological things do you think may be at play?
Oh, I think for women, for everybody, we know that there is a connection with depression and how you feel, just kind of, the good chemicals in your brain, that could be increased when you're eating more healthy. Your body is not so worried about fixing other parts. I always think of it as if you're taxing your body or challenging your body with something for it to do besides working on your sperm or working on your heart or working on, it's going to divert all the attention to the prioritized list. And so
triage.
I think,
Triage
right.
theory.
And I now, and I can't, a lot of people want to know, cause and effect, but I always think about what Campbell said about Dr. Campbell about phytonutrients and, the danger of reductionist thinking when you think, oh, one compound, that's the magic answer. It's, omega-3s, so you put it in a pill and give it to somebody, but there's things about eating a plant-based food that we can't possibly know. It's this symphony of things, this orchestra of things that happen that improve, our physiology, our brain health, our sense of well-being. And I've experienced that personally too, and, you eat in the past when I would enjoy the heavy, greasy meal with meat, but then I would always feel badly, or I would always say, oh, I love that tuna sandwich, but it always makes me feel a little funny. And I could never put my finger on it, but it would always make me feel a little funny. And I think there is things for mental health and mental well-being that is affected by nutrition. And that, of course, plays into sexual health. I think that's a big part of it.
It's quite extraordinary that still there's so much denialism with respect to even just a connection between what we eat and our health, because it's so profound. And I've now been doing this for 20 something years, and I've seen so many things that I didn't think could be improved, from skin to lifelong asthma to like just these little things that you like, infection rate, getting sick. So many things with thousands of people now, that there is no question how powerful, and the most powerful thing is diet when it comes to improving your health. And really people say, oh, can it really help everything? And I can't say that, science would never allow you to say everything can be cured by a plant-based diet. But my goodness, if there's anything ever been closed and there's been associations before, this just seems like it helps so many things in so many profound ways.
It does. The frustrating part is it's not out there. It doesn't seem to be able to make the headliner, partly because of being suppressed by big meat companies and other people that don't want, because if you search the literature, it's there. You talk to Michael Greger, it's there. It's just not in the front page. And that's so sad, because that we spend, the cost of medicine is just incredible. And, the problem is hospitals only make money when people are sick. They're not we have to focus our attention and our monies on prevention, teaching, education, and it would help our health, health crisis. I mean, the cost of healthcare.
Pills, potions, screenings, and procedures. That's how you make money.
Right. And
I mean, and I don't mean that in a derogatory way either, or a condescending way. Like, this is the product we have, and this is what we're selling, which is why I wish we call them clients, not patients. This is the product we have. This is what we're selling. And if I'm not selling that and I don't have a way to bill, I won't succeed as a company. This is just, capitalism 101. And instead of making it evil or bad or negative, that is what they have to sell. And when you look at dietetics, even having gone to school like Juliana did, she had to go beyond what her education was, because dietetics, I don't know, you explain it best of what really modern dietetics is about.
Well, I hate to say this, but I really do feel, the truth is, I feel like it's a hot mess out there. And I'm often horrified at what my colleagues say in art and media, in professional conferences, between each other. It's horrifying to see people. I've seen people go crazy when they hear, you have a client that is pregnant and went vegan. Like, what are they, crazy? You hear these crazy things. Right. And the extent of where the continuing education can be so expensive, and we're required to keep up our, continuing ed, of course, and it costs money. And there's a lot of them that you can get free continuing education because the dairy industry is sponsoring it, or the beef council is sponsoring it. And, it's just, there's so many levels to it that it's deep. And I that's why we're so happy to have you here, Cathy, because people like you are making a difference, because you are doing this on the ground level. And that's where I think, like, all you're doing, even if you just plant a seed in your patients,
no pun intended.
I decided.
I'm sorry I had to go there.
Yeah, no, it's good. I after trying for so long to handhold and have them, I have found my own satisfaction, and I've come to peace at saying, just educating them, and then it's sort of like leading the person to water. You can't make them drink it, right? Yep. But I find that, I have done my part, and I'm very passionate about it. And I just, like a broken record, every time they come back, hey, did you try this? And, hopefully one or two, it'll stick. And, it's the most important thing you can do, not only for yourself, your family, the environment. One person would make a difference, just eating plant food. I mean, it really, and then once we get the critical mass, and I think compared to the 80s and compared to, we've come a long way.
Yes.
I think it's wonderful. I'm so excited. I mean, the fact that I was able to go to a course on plant-based nutrition. I mean, this, to me, there's, I thought, as oftentimes still I look around and I'm like, I'm the only one out here, in terms of when you ask me about my colleagues, when I talk to them about it, I talk about it in shareholders meetings. I said, I'm going to try and start this plant-based program for our patients. And they said, okay, go for it. But insurance is not going to cover it. That's one of the biggest drawbacks, right? We have to change fundamentally.
Yes, that's true too. Yeah, because a lot of clients will come to me out of, they want to have a change and their doctors aren't supporting them. And, I don't take insurance. I can't. Like, it's very hard to get refunded for even dietetic services. So that is an issue too.
Right.
Yeah,
so
and one of the other things when we talked about research earlier, and this is something, we've been saying, as we're building our podcast, one of the things we really want to get to the point of doing is taking our wider network of people like you and doing an aggregation of a bunch of NM1s. So we can't publish in a journal because we don't have IRB on it. I really don't care at this point. I mean, it used to be that you need to work for one of the three major networks to do news, and now people can do news in their bedroom on YouTube. And, people get
Right.
offended by that and say, well, they're not real journalists, or someone's blogging is not a real journalist. And the answer is they're probably not that far off from what the people are with the fancy sets. I mean, they make a lot more money,
Right.
but the fact of the matter is there's a lot of smart people out on YouTube. There's a lot of smart people out on the internet. There's a lot of crazy people too. I agree. But my point
Right.
here in our little world is, I know how to do research. Juliana knows how to do research. You know how to do research, and we are working
Right.
with other people that do too. And there's really no reason why we can't aggregate and use our audience and eventually use crowdfunding to be able to look at things like this. Because
Oh,
for this,
I'm in.
it could be just
Absolutely.
coming up with those set of surveys and saying, okay,
Yes.
here's a set of surveys. And here's some food. We're going to, we've got we've got a lifestyle transformation program that we're going to be announcing soon. It's a 6-week program, and it's all automated. And so the point here will be is that if someone did this for six weeks, one of the things we should have is some kind of assessment for this.
Outcome measures.
Yeah, exactly.
Absolutely.
Because, it's as accurate as most of these questionnaires. And again, this idea that something has to be in the journal to be valid. And the truth is that lots of stuff that are in journals is invalid.
Right. And
I know they
harmful.
are.
And also to piggyback on what you just said in a real optimal light is that, I've been teaching dietitians and doctors and nurses for many years, and the audiences have gone from just a few here and there that heard about it from their patients or saw a movie or something, and now there are hundreds of people showing up at these conferences. Yeah, thousands.
You've spoken in front of 1,500 or
yeah,
something.
I have, and that's really to me.
That's exciting.
Yeah, it's exciting. I
Yes.
think it's definitely changing, and I love stories like yours because you lived it, you're doing it, and you're inspiring people everywhere. And I'm so happy and inspired by meeting you, and I'm so thrilled with what
that's
you're
nice.
doing.
Well, I thank you. So I'm so grateful for you and Ray to have these podcasts to just introduce the concepts to people, and just have them inquire more, be curious, try
Right.
it. I always say it's 6 weeks of your life. Nothing else has worked so far.
Right.
Yeah,
It's 6
exactly.
weeks of your life.
Just
Why-
6 weeks.
Just try.
Yeah.
Just try it.
And maybe this, what's really going to be great, and maybe an indirect outcome of us being able to do this podcast together is you can, your clients come in and, you can spend an hour and a half with us too. And you can say, here's a book, read it. Here's a book,
Right.
read it. Here's a bunch of recipes, try some and listen to this. Just listen to us having this conversation. Do you really want to be that person that doesn't change? But what I would say to them right now, and I've said it on here so many times, until the new diet is equally convenient, familiar, and enjoyable, you do not have a choice. One or more of those will dominate your plate. And your new favorite food is just going to be in new habits the way your current food that caused your erectile dysfunction has.
Right.
It's just those habits just have to change. And how are you going to change the habits? Well, you're going to have to go into the new diet and not have exceptions. You don't fall in love with a new man or a woman by,
Right.
hanging out and banging the old one every now and then on the sides. Like, you can't do that. It doesn't work that way.
doesn't work, no. That's
Even
what
though
my
they may be
therapist said.
comfortable,
Yeah.
you broke up with them for a reason, right? But it may be comfortable to get together. Maybe you had a great sexual relationship and you don't yet in this new one or whatever. But the problem is that we're way more complicated than that as humans. We're way
Yes.
more complicated. And food is probably more complicated than sexual relationships. I mean, it's everywhere, and everyone thinks they're an expert, and everyone will, people may not just, break out at Thanksgiving dinner and talk about the best way to have an orgasm, but they absolutely will talk about, protein, right? So
Right.
there is this, it's not only that we have a bunch of people that are misinformed about things and a lot of conflicting conundrums that are out there, like we talk about on Macro Confusion, but also the fact that everybody wants to be an expert and talk about it. And they do. And so,
That's true.
anyway, hopefully in the future, this podcast itself might, become something that can be part of what you're able to do. So we have that. And we really want to have you back on again. We definitely need to do that. And we definitely need to figure out how we're going to do some kind of crowdsourced, who doesn't want to do the crowdsourced sexual dysfunction?
No, I think that's a draw. I think
studies.
That's a draw. Like you said, it's a draw, the sexual health, and then anything that could alleviate pain, like stone pain, or, that's another big, way to draw people in. You got to give them an outcome that is desirable, so much so that's worth it, right? The ROI, right? It's all about risks and benefits, ROI. So I think that we should definitely focus on this in terms of trying to get, and it's not for a deceptive way. It's all good. It's all good. The erections are going to work better. You're going to be healthier. You're going to be happier. I mean,
it's a win-win-win.
How could you? Yeah, it's a win-win-win.
So, Cathy, if you could give this to your patients, if the patients that are open to listening to you, like, what would you say if you had that time and that opportunity? What would you say to them besides all the amazing things you said already?
I would say the most important thing that you can do for yourself would be to go towards plant-based food. Go towards plant-based food as much as you can, as long as you can. And, and a lot of people, they understand, everybody knows you should eat more fruits and vegetables. And it's so nice to have a resource like you and Ray. And if they can't do it themselves, I can refer them to for professionals like yourselves that can to help them, because it's hard. It's hard to change. It's hard to get out of that addiction of salt, sugar, and fat. People don't understand it. Food is such a reliable comforter. It's reproducible every time. It's the go-to drug for a lot of us, and it's hard to break away from that. But the most important thing you can do is get that control back. And I always say the great thing is you are in total control. You have control of what you put into your mouth every single day, multiple times a day. You are in control. And, sometimes it empowers a lot of people. So I think,
Beautiful. But also, I think that the new ROI is going to be regular orgasm incentive.
Absolutely. That's going to be a good return.
That's going to be every time you hear an ROI, I'm like, there's got to be an acronym.
We should dangle that.
Absolutely. So, well, thank you so much for joining us today. It's been really great, and we had such a great time in Thailand. Can't wait to do it all again, and we'll definitely have you back on.
Wonderful. I can't wait for it. Thank you so much.
Yeah, thank you so much, Cathy. Keep up your good work, okay?
Oh, thank you. I will.
Okay. So provocative and so inspiring.
It's really great.
Thank you for joining us on this leafy green path to good health and good sex.
She said it. It's always the food. So remember, keep eating right.
Thank you for listening to Science and Saucery. For more details about the content in today's show or to contact Juliana and Ray, please visit us at healthspansolution.com.
Welcome